Adult Respiratory Distress Syndrome, ARDS, is a core critical care medicine disease state that all inpatient healthcare practitioners need to be familiar with. This video represents the most up-to-date information about its diagnosis and management. Thanks for watching, and thanks for learning with us.
Medical Specialists Associates, making medical education more accessible.
Hello, this is Nazir Habib. Today I'd like to discuss the management of ARDS as is currently recommended by multiple societies. And this has become a very important topic at this time since we're facing a crisis all over the world with coronavirus. So I think this is the best time for us to review that we're managing these patients in optimum fashion. Let us start with first reviewing a case. Here's a 22-year-old female with a history of obesity, BMI 35, is seen in the emergency room with 1 week history of shortness of breath associated with fever and myalgia. She is not on any prior medication. In the emergency room, her temperature is 102, respiration rate is 30 per minute, her heart rate is 112, blood pressure is 100/70. She is quite alert, although she's very short of breath, and on a non-rebreather mask, her O2 sats are only 86. On chest examination, she has diffuse bilateral rales. Her lab tests immediately come back positive for influenza A, and her procalcitonin is markedly elevated at 20. Her hemoglobin is normal, her white cell count is elevated with greater than 10% bandemia, and her platelet count is 230. Her electrolytes are unremarkable, except her BUN is slightly elevated at 26. Her initial blood gases in the emergency room showed her pH is 7.35, PCO2 is 38, and her PO2 is 52 on 15 liters of oxygen administered via a non-rebreather mask. Her chest X-ray shows diffuse pulmonary infiltrates, and she is intubated in the emergency room soon after the first blood gas. Her initial blood gases show a pH of 7.32, PCO2 of 50, and a PO2 of 70 on 100% oxygen. Her ventilator setting is 450 cc's tidal volume on volume control. Her actual weight is 110 kilos, although her height is only 64 inches. The respiration rate is set at 16. Her O2 is set at 100%. And she is initiated on 5 centimeters of PEEP, and the first blood gases are drawn. The blood pressure is stable, and at this point, the patient has received antibiotics and Tamiflu appropriately for community-acquired pneumonia associated with influenza virus. Let us review the management of ARDS and the definition of ARDS. First of all, the definition of ARDS currently used is the Berlin definition. This includes the history of timing, that within the first week of a known clinical insult, the patient develops new or worsening respiratory symptoms. On chest X-ray, one should see bilateral opacities that are not fully explained by effusions, collapse, nodules, or chronic interstitial lung disease. The origin of the pulmonary edema should not be cardiac. This requires objective assessment, possibly an echocardiogram or BNP, or other ways of excluding cardiac failure or fluid overload. The third criteria is very important. When you look at the oxygenation of this patient, it should be categorized in 3 categories based on the PF ratio or the PO2-FiO2 ratio. Mild ARDS is considered if the patient's PO2 is between 200 and 300 with a PEEP of at least 5 centimeters. Moderate ARDS, based on the PF ratio, is between 100 and 200 with a PEEP of at least 5. Severe ARDS is considered when the patient's PF ratio is less than 100, associated with the PEEP administered at least 5 centimeters. The development of ARDS has many causes. There could be direct insult to the pulmonary tissue, such as aspiration pneumonia or community-acquired pneumonia or hospital-acquired pneumonia or sepsis. Less common causes of ARDS are inhalation injury, pulmonary contusion, fat embolism syndrome, near drowning, and recently, as we have noticed, influenza and coronavirus may be a very significant factor in causing a direct insult to the lungs. Indirect insult may be associated with sepsis in another part of the body, or trauma, especially long bone injuries, or septic shock in another part of the body. Less common causes of ARDS include acute pancreatitis, transfusion-related acute lung injury, multiple trauma, burns, head injury, or drug overdose. Ventilator-induced lung injury is one of the things that we're very concerned about. What happens when you intubate somebody and we deliver excessive high tidal volumes is that the alveoli rupture and create more lung injury and flooding of the alveoli with cytokines and interleukin, and then that causes injury to the healthy part of the lung. In ARDS, we have to consider the baby lung concept, where 80% of the lung essentially is injured, and we must maintain the integrity of the other healthy alveoli. So barotrauma is due to high pressure. Volutrauma is considered to be from excessive tidal volumes delivered, and biotrauma is a release of mediators of lung injury, such as cytokines and interleukin. The use of non-invasive ventilation or BiPAP in ARDS is recommended if the patient's PF ratio is greater than 200. In other words, they have mild ARDS. And if the patient is hemodynamically stable and alert and able to accommodate non-invasive ventilation, as I have presented in my other talk on non-invasive ventilation, one may continue non-invasive ventilation in usual cases of ARDS. The patient should be admitted to the intensive care unit and monitored for improvement. If the patient improves with an improving PF ratio or a stable PF ratio by 24 hours, one should continue the use of non-invasive ventilation. However, one must be very cautious because sometimes delay in intubation may increase the mortality. And currently in coronavirus, even in mild ARDS, it is recommended that we intubate the patient rather than use non-invasive ventilation. So let us look at the recommendations for managing ARDS based on recent guidelines published in multiple journals. If the patient meets a Berlin definition for ARDS, that is, they have acute onset, respiratory failure is not due to cardiac edema, they have bilateral opacities on the chest X-ray, you initially would like to diagnose the cause of the ARDS. Always measure the patient's height and calculate their predicted body weight. I often, on rounds, am told the patient's actual body weight, but what we're really interested in is the predicted body weight, because the tidal volume that we deliver is based on the predicted or ideal body weight. Oxygen therapy and ventilatory support should be started according to the disease severity. I'm going to reiterate, mild ARDS is between 200 to 300 PF ratio when at least 5 centimeters of PEEP is administered. Moderate ARDS is a PF ratio between 100 and 200, and severe ARDS is when the PF ratio is less than 100. So what are the ventilator strategies that we basically must implement immediately in the emergency room when we intubate a patient? The patient should be placed on 6 cc's per kilogram based on their predicted or ideal body weight, and immediately target the airway plateau pressure to be less than 30 centimeters of water. This should be performed immediately upon intubation. This is a strong recommendation. The patient should not be left with a plateau pressure of greater than 30 centimeters after intubation. Once the patient is intubated and the patient is placed on CMV mode, one must calculate the ideal body weight. Initially, one must start a PEEP of minimum of 5 to 8 centimeters, depending on the PF ratio. One will administer tidal volume of 6 to 7 cc's per kilogram ideal body weight, check the plateau pressure immediately, and also place an end tidal CO2 monitor. One should obtain a blood gas on 100% oxygen, as it would be much easier to calculate the PF ratio, which is generally difficult to guess until we have done a blood gas. Following that, one should titrate the PEEP based on high PEEP ARDS-net protocol or lower PEEP. These are the two protocols. Generally, one is using the higher PEEP protocol, where the PEEP may go up to 24 and the patient is on 100% oxygen. So, as I've mentioned, we should check the plateau pressure is less than 30. If the plateau pressure is greater than 30, one should continue to lower the tidal volume to 5 cc's per kilogram. Currently, we also are checking the driving pressure based on the plateau pressure, which I will discuss in the next slide. One may recruit the lung and increase the PEEP gradually by 2 centimeters every 15 to 20 minutes. This is a stepwise increase in the PEEP. This is recommended by some authorities. One should again aim for a driving pressure of less than 15, as some studies have shown that this is an important factor in predicting lung injury. Generally, when we're monitoring fluid boluses, one should look for fluid-responsive patients and not automatically give patients fluid boluses. If the patient is in septic shock, they have lactic acid greater than 4, one should still use mechanisms of assessing fluid responsiveness and echo. Monitor the patient for dead space ventilation by watching the end tidal CO2 and obtain an echocardiogram to evaluate the right ventricle, which may become strained or dilated if we apply too much PEEP. Remember, 25% of the patients in the intensive care unit will have some sort of right ventricular failure. So what is the driving pressure? The driving pressure is the difference between the plateau pressure and the PEEP applied. As we increase the PEEP, one should lower the driving pressure, although the plateau pressure may also increase. The goal of this measurement is to maintain a driving pressure of 15 or less, and that will ensure that one is administering enough PEEP to recruit the lung. So the ARDS lung protective strategy basically ensures two things. One is that we do not over-distend the alveoli, and that target should be 6 cc's per kilo, and monitoring the plateau pressure does not exceed 30. At the bottom end of the curve of ventilation, we must ensure that adequate PEEP is applied to recruit the lung and avoid any kind of injury to the lung from inadequate PEEP. And the best way to do that is to continue to use the driving pressure to ensure that we are in this sweet part of the curve to ensure adequate ventilation that is safe and avoids lung injury. In order to achieve this, we must also sedate the patient adequately. The sedation protocol that we use is based on the Society of Critical Care Medicine recommendation, which is the PADIS scale. The RASS scale should be -1 to 2 initially. One should start the patient on fentanyl and propofol or Versed infusion and avoid Precedex initially, as this will not adequately sedate the patient. Generally, this is what's recommended by the Society of Critical Care Medicine, that we initiate fentanyl and propofol or Versed. It is extremely important for the nurses and the RTs to monitor the patient for patient ventilator synchrony. This is essential. If the patient does not achieve ventilator synchrony, they will develop lung injury. We must avoid tidal volumes greater than 6, and we must avoid the patient from bucking or having spontaneous respiration tidal volumes greater than 6 cc's. In this situation, we often resort to paralyzing the patient using a neuromuscular blocker. So in moderate or severe ARDS, neuromuscular blocking agents may be useful in the acute phase, generally considered the first 24 or 48 hours. The point of this is to reduce the biotrauma from excessive tidal volumes. We can then reduce ventilator-induced lung injury. The recommendation by the Society of Critical Care Medicine is we use a drug called cis-atracurium as an infusion or as boluses. This neuromuscular blocker is not a steroid, and therefore, when has advantages over steroid-based neuromuscular blockers, and also it is metabolized by the Hoffman degradation. That is, it does not need the kidneys or liver to metabolize it. It also has perhaps anti-inflammatory properties, which may help in lung injury. Recruitment maneuvers have had various studies that have looked at different ways of increasing the recruitment of lungs. One is a stepwise intermittent increase of PEEP, maintaining a driving pressure of less than 15. This has been published by Marini and other authors and has recently been used in many studies. The other way is to maintain a CPAP pressure of 30 to 40 centimeters for 40 seconds and then return to the baseline PEEP that was previously administered to the patient. In a meta-analysis, the odds ratio of mortality was 0.88. However, in the guidelines, this is a conditional recommendation. In the corona patient virus, infected with the coronavirus, it is recommended to use the continuous CPAP methodology of recruitment rather than the stepwise. So let us review now what we are doing. In mild ARDS, we should initiate non-invasive ventilation. If the patient remains stable, one should continue non-invasive ventilation as long as the PF ratio is greater than 200. This does not apply to the coronavirus patient. In moderate ARDS and severe ARDS, one should implement controlled mechanical ventilation with 6 cc's per kilogram predicted body weight, maintain a plateau pressure again, less than 30, consider high PEEP in moderate and severe ARDS, maintain a O2 sats of 88 to 95% and a pH greater than 7.25. If the patient's PF ratio is less than 150, one should initiate deep sedation and prone positioning, as well as neuromuscular blocking agent with lung recruitment maneuver. If the patient's PO2 and FiO2 ratio is less than 80, one should consider other alternative therapies on a case-by-case basis, including VV ECMO. Let us talk a little bit about prone positioning. Why is prone positioning useful? It delivers a more homogeneous thorough pressure. The dorsal lung is better perfused and aerated, thereby decreasing intrapulmonary shunt. So most of the edema then by gravity is in the sternal part of the chest. This improves the ventilation perfusion matching, improves lung recruitment, and there is less ventilator-induced lung injury, and it may decrease the release of inflammatory cytokines or biotrauma. So proning should be used in ARDS with a PF ratio of less than 150, unless it's contraindicated. This is a strong recommendation by the society. The benefits include oxygenation, lung recruitment, and reduced lung injury. The duration of proning should be more than 12 hours per day. One must adhere to 6 cc's per kilogram predicted body weight. Use neuromuscular blocking agents as discussed. We need special teams in order to perform prone positioning, as it may be associated with multiple complications. The discontinuation of prone positioning should be when the PF ratio is greater than 150 with the PEEP applied less than 10 and the FiO2 is less than 0.6 for at least 4 hours during the supine position. The absolute contraindications to proning is burns or open wounds on the face. The spine is unstable. You have pelvic fractures. You have life-threatening circulatory shock, increased intracranial pressure, and BMI over 40. The main complications are facial edema, pressure sores, displacement of lines and tubes, airway obstruction, arrhythmias, and hypotension. There are non-ventilatory based strategies recently for ARDS. One is ensuring that you use conservative or fluid restriction in patients with ARDS. So one must use some methodology to assess if the patient requires fluid. Otherwise, one should be using fluid restrictive strategies. One can use the echo, look at the right ventricle and left ventricle. Generally, steroids for influenza are not recommended, and neither are they for coronavirus, except in patients with severe ARDS when there might be a cytokine storm. ECMO and extracorporeal CO2 removal is further looked at if the patient's PF ratio is less than 80. And this should be a case-by-case evaluation. So indications for ECMO are profound hypoxemia with the PF ratios less than 80 when you have used invasive ventilation, optimizing the tidal volume and PEEP for at least 3 to 6 hours. There's severe uncompensated hypercapnia with severe acidosis despite appropriate ventilation persisting for 3 to 6 hours. One may benefit for ECMO and ECOR. Contraindications are mechanical ventilation greater than 7 days. Patient has had a stroke or a CNS catastrophe. The patient has irreversible condition and is not a lung transplant candidate. Patient cannot be anticoagulated for some reason. Patient has multiple organ failure, and generally age over 70 is considered a contraindication. When we look at the recommendations for COVID currently by the Society of Critical Care Medicine, COVID-19 with mild ARDS, they recommend to intubate the patient. Do investigate for bacterial infection. I generally recommend obtaining cultures and looking at the patient's procalcitonin level or bandemia, as the patient may have co-infection, and initiate appropriate antibiotics, usually Recefin and azithromycin. Target the O2 SAS to 92 to 96. Use conservative fluid strategy, as we've discussed. Empiric antibiotics may be initiated, and we're generally uncertain about the use of systemic corticosteroids in mild ARDS. However, when COVID-19 patients progress to moderate to severe ARDS, one is going to implement the higher PEEP protocol from the ARDS-NET protocol, use neuromuscular blockers such as Nimbex or cisatracurium to facilitate our ventilation role, use traditional recruitment maneuvers and avoid the stepwise recruitment maneuvers, prone the patient for at least 12 hours per day, and especially when the PF ratio is less than 150. And one may consider a short course of systemic steroids, generally 2 milligrams per kilogram of solumedrol per day. Antivirals, chloroquine, anti-interleukin-6 are highly debatable, and one would discuss this at your own institution, whether to implement them. One should also consider referral for VV-ECMO in young patients who are appropriate candidates for ECMO or ECOR. So in summary, one should initially start the patient on regular mechanical ventilation, administer PEEP, titrate the PEEP by 2 centimeters at a time, watching the patient's blood pressure and end-tidal CO2 and assessing the driving pressure, check the plateau pressure regularly. One should apply neuromuscular blockade when the PF ratio is less than 200 and they're intubated. Administer prone positioning if the PF ratio is less than 150. Consider solumedrol 1 to 2 milligrams per kilogram for 3 days. If the patient improves, then continue it for 5 days. One should consider ECMO if the PF ratio is less than 80 in a young patient, and one should consider recruitment maneuvers depending on the patient's condition. Pulmonary vasodilators include nitric oxide, which may be titrated based on your institution if it is available.
Thank you for watching. Please consider sharing your suggestions or comments with us at the email address listed. And please also continue to visit with us at our website and our YouTube channel. To be instantly notified of when we release new content, please consider subscribing to our YouTube channel as well. Thank you.